Pittsburgh.
Oh, okay. Hello everybody. My name is Jim Squires. Here at the Children's Hospital of Pittsburgh with the Center for the Rare Disease Therapy. I'm going to talk today via webinar. This is my first webinar, so yeah, this goes. Title of the webinar is Liver Transplant for Pediatric Metabolic Disorders, and this is a clinician's perspective. Before I begin, just a few housekeeping items. At the end, this should be hopefully about a 30-minute talk and PowerPoint presentation. At the end, we hope to be able to answer as many questions as possible. I think there should be an option to submit a question on the webinar, and so as I'm talking, as questions kind of come up, feel free to submit those as they come to you. We will kind of catalog them, and then they'll feed them to me afterwards, so that hopefully we can address any additional questions you guys may have. I think secondly, this will be available online, so it's being recorded and we'll put it up all online. And I think obviously any questions or issues that we don't get to or don't have time for, there'll be contact information at the end for you to reach out to us so we can make sure we can help as much as we can. All right, so these are the learning objectives. We're going to try to understand the conceptual basis of liver transplant decision-making for metabolic liver disease, kind of broad. I think, you know, the three diseases I'm going to cover here are Tyrosinemia, maple syrup urine disease, and Crigler-Najjar type 1. I picked these not because they are comprehensive, and I think there are plenty of folks on the webinar here who have or are related to or care for children who have different metabolic diseases than the three that are listed. But I'm going to use these three to kind of build a framework around which we approach transplant decision-making for metabolic diseases in general. Before we begin, just a little bit of physiology, because I think it helps put things a little bit in context. So, you know, if anybody on the webinar has been to medical school, this is kind of the classic slide that your teacher will throw up to, you know, intimidate you, and it does as it relates to kind of metabolic processes in the body. So this is every metabolic disease or every metabolic process kind of mapped out all in one figure. So this is obviously way too complicated. You would never be able to fully understand this, or at least I wouldn't. And so, you know, at a higher level, I think you can think about metabolic processes within the body looking at something like this. But even for me, I think this is, it's a little too complicated. It's still a little too busy. There's a lot going on. And so I kind of go up to the 10,000 foot view. And when I think about metabolic disease, I really think about it in this kind of simple format because it helps you kind of break down what's going on in individual patients and understand the process. And at the end of the day, with metabolic processes, you have a substrate or something that's kind of coming in through the pipeline. You have different you have different enzymes, and those are kind of you know, signified by the E1, E2, E3. Along the way, you may have intermediate metabolites of things as this substrate's broken down. And at the end of the line, you got an end product. And so that's how I approach metabolic diseases. And so depending on where the defect is, let's say the first enzyme in the process is defective. Well, what you're going to see is a measured increase in the substrate. And depending on what this substrate is, you may see different clinical manifestations. If it's one of the enzymes further down the pathway, you may see increases in intermediate metabolites. If it's the last protein in the pathway that's affected, you know, maybe you'll see a decrease in the end product. And so these are the ways that we look at metabolic disease and what we measure in order to help make diagnosis and prognosis. So what about transplant, right? I think this talk really is about transplant and the decisions surrounding transplant for these diseases. And so when you think about transplant for metabolic disease, again, a little historical perspective here. This is the Children's Hospital of Pittsburgh's experience. We have two graphs. The one on the left looks at our early experience, 1980 to 86, and on the right, a little bit more recent. Oh, 96. Let's see, those popped up. Let's bring those down. Sorry, guys. Okay. So on the right, we have you know, more recent experience from, you know, the 96 through 2016. And I think what you can see here is that, you know, this blue pie piece, this is the metabolic disease, and what's happened over time is that we've increased the percentage of patients that we're transplanting for these diseases. But when you think about metabolic disease, this is really an umbrella term, right? So this encompasses a huge variation of multiple diseases and phenotypes. And again, looking at our experience, the timeline's a little bit different. We're now looking at 81 through 2015. We had performed 334 liver transplants for metabolic disease, and this is the breakdown of the diseases that we've transplanted here at the Children's Hospital of Pittsburgh. I think when you look at how have we done, this was a 2012 paper. George Mazaregas, who is our head transplant surgeon, and Jerry Bockley, the first and senior author here, is our metabolic geneticist. I think the story here is that we're doing well and we're doing better. I think this is looking at kind of 3 decades of transplant and metabolic disease, and what this graph shows is kind of the percent or the ratio of patient survival. So if you were transplanted for a metabolic disease in the 80s, your survival, was not nearly as good as it is now in the 2000s, and is even better here in the 2010s. Some of this has to do with error of transplant and improvements made in transplant in general. But a lot of it has to do with our understanding of metabolic disease and how transplant can improve that process. So, here's a follow-up paper that was, authored by my colleague, Dr. Patrick McKiernan, who's one of our hepatologists, with Rakesh Sindhi, who's one of the transplant surgeons, as the senior author. And what they did is they looked at UNOS data. And UNOS stands for the United Network for Organ Sharing. And this is kind of how, in the United States, organs are allocated and doled out. And they looked at kind of evolving trends over time for metabolic liver disease. So this is one of the figures from that paper. And I think the story here is, again, looking at era 1, which was kind of in the 80s to 90s, era 2 is 90s to early 2000s, and era 3 being later. What you see is that these bars are getting more colorful, and more colors mean more diseases. And so there has been an increase in the number of diseases for which liver transplant has really become a viable option in therapy. And I think we'll talk a little bit about that throughout this talk. But again, it's also recognizing that, when we talk about metabolic disease, we're really talking about a huge variation in different disease phenotypes. And when you think about metabolic disease in the liver, there's kind of different ways in which that disease can present itself. And so what Pat and the authors did were they looked at the different metabolic diseases and they broke it down. And how they broke it down is to look at, does this disease, is the defect contained solely within the liver? Yes or no? And is there any manifestations of disease outside the liver? And the reason this is important is because when you look at outcomes for these diseases, what you see is that this 1B group, right? So that's the patients who have structural disease but have extrahepatic manifestations. These patients historically had significantly poorer outcomes. Now, that's not to say that it's not that these patients should not have liver transplant considerations, but I think it's recognizing that grouping all metabolic liver diseases into one term can be a little bit misleading, in that we're really talking about a lot of different diseases, as I'm sure many of you know. Okay, so we're going to go back to kind of our picture of how we think about metabolic disease to start talking about some specific diseases and how we think about transplant, right? So first, we're going to talk about tyrosinemia. So in tyrosinemia, the substrate is tyrosine. So that's what's kind of coming down the pipeline. What you want to have at the end of the day is something called fumarate. So normally what the body does is it breaks down tyrosine into fumarate. But what happens is you're unable to do that. And so you get increase in some of the intermediate metabolites, which end up causing some of the problems associated with tyrosinemia. So again, here's just another picture of the metabolic pathway. And down here is the enzyme that is deficient in those with tyrosinemia. So what you see is you have increase in these intermediate metabolites, but it's really not, in this case, these metabolites that cause issues. It's that increases in these intermediates get kind of shunted over to what is ultimately measured and causes the problem, which is succinylacetone. So natural history of tyrosinemia, there is an acute form of tyrosinemia where patients will present with liver failure kind of at a very young age, prior to 6 months of life. If you look at the histology, what you'll see is what we call neonatal hepatitis and micronodular cirrhosis. So this picture here is actually a normal liver slide. And someone who has tyrosinemia, again, I think what you can appreciate is kind of these little tiny circles, and this is the micronodular cirrhosis that's kind of classic for tyrosinemia. There's a subacute form where patients present more with failure to thrive. They'll have hepatomegaly or a large liver. They'll have rickets, which is a bone disorder secondary to vitamin D deficiency, and they can have kidney disease as well. And then there's a chronic form, and this chronic form is generally present in older individuals. Again, they'll have rickets and hepatomegaly. They notably will have an increased risk of hepatocellular carcinoma. And then they can have something called porphyria, which is defined as paresthesias, autonomic dysfunction, and paralysis. So what do we see in labs in someone with tyrosinemia? Again, you have this enzyme at the end of the pipeline that's defective, and so one thing that you'll have is elevated tyrosine levels. But tyrosine elevation is not specific, so it's not diagnostic. If you see elevated tyrosine, you can see that in several different metabolic diseases. You'll definitely see it in tyrosinemia, but it's not the sole finding. And more what you'll see is, again, this succinyl acetone that we talked about previously. And you'll see this in the urine, and you'll see it in the blood. And elevations in succinyl acetone are essentially diagnostic for tyrosinemia. How we measure this is in the urine, because it gets filtered through the kidneys. We take a urine sample, we measure it, and if it's elevated, you essentially are diagnosed with tyrosinemia. We also will see metabolic liver dysfunction. Again, most of these patients do have synthetic and evidence of liver dysfunction. You'll have ALT and AST elevations. You'll have elevations in the bilirubin. These are markers of liver disease that we get in patients. And oftentimes, particularly in those who have hepatocellular carcinoma, you'll have an elevated alpha-fetoprotein, which is, again, a blood marker that we use to look for liver cancers. Again, diagnosis is with urine succinylacetone elevations. You can also use skin fibroblast enzyme assays, so these are other ways to diagnose this. There is genotyping possible if needed. And importantly, here in Pennsylvania and many other states, tyrosinemia is included on the newborn screen. So again, historically, what was the natural history of tyrosinemia? It wasn't good. So again, this is looking at those patients who presented less than 2 months of life, 2 to 6 months, or greater than 6 months. And what you see is patients who present young did very poorly. Many of them died, and there wasn't a lot of treatment options. And again, this paper is from 1994, so quite old. But what was discovered was that in the Lancet in 92, and then again, kind of confirming in a paper in 1995, there's a substance called NTBC, which was developed and discovered. And what this substance does is it actually goes in and interrupts the process above where the succinyl acetone intermediates are produced, because that's what ends up causing most of the damage. And what we saw, or what they saw, I'm too young for this, but what they saw when they gave patients in TBC is that you get a rapid reversal of almost all aspects of the disease. And so at a dose of 1 mg per kg per day, you blocked about 99% of the substrates going through. If you maintain a certain blood nitazone level between 40 and 60, you get a really good outcome. Notably, you still will get elevations in tyrosine, right? So you haven't kind of prevented that from being elevated. And tyrosine can affect ocular problems. And so ultimately, at the end of the day, the treatment for tyrosinemia is NTBC combined with a low tyrosine diet. Pat McKiernan did look at kind of the experience of liver transplant. He came to us from Birmingham, England, and so he had a recent publication looking at that. And when you think about indications for transplant for tyrosinemia, this, along with other metabolic diseases that present with acute liver failure, that is a very clear indication for liver transplant. So patients who are already coming in, the liver is failing, transplant may be the only thing to offer in order to really interrupt the natural history of that. In tyrosinemia, I think one of the things that we always worry about is the potential for development of hepatocellular carcinoma. And so even in patients who are diagnosed, caught early, and treated, there is still an increased risk for the development of cancers. And so in patients who are older and there is a growing liver lesion or an AFP that's rising or doesn't normalize, this would also be an indication for tyrosinemia to look at liver transplant. So moving on from tyrosinemia, we're now going to talk about maple syrup urine disease. And so this is one that is kind of special to my heart. We care for a lot of patients with MSUD here at the Children's Hospital of Pittsburgh. Here it's a little bit more complicated because it's not just one substrate, it's actually 3 substrates. Good news is that there's really only one enzyme, or it's an enzyme complex that we have to worry about. But obviously with those 3 substrates, you have 3 end products that you're looking at. And so here that enzyme complex is defective. And so what we see is elevations in the three substrates. And the three substrates that we're talking about are what we call branched chain amino acids. So this is leucine, isoleucine, and valine. And so in patients who have MSUD, they have inabilities to break down these branched chain amino acids, and so elevations in those branched chains. Now again, it's a little bit even more complex beyond that because this enzyme complex is actually three separate enzymes, and any one of these can be defective, leading to the MSUD phenotype. Again, another picture of the metabolic pathway. You see at the top your branched chain amino acids. They kind of come together through the branched chain complex. When that's defective, you'll get elevations in the branched chain amino acids. So how do you diagnose? Again, you look at the branched chain amino acids. It's really suggested by elevated branched chain amino acids and allo-isoleucine, which is kind of pathognomonic. You know, what's the problem that we worry about with MSUD? As with many metabolic diseases, it's kind of neurotoxic, and it's actually this intermediate metabolite, this alpha ketoisocaproic acid, that is able to kind of get into the central nervous system and cause damage. There is fibroblast or lymphocyte testing for enzyme activity, or there is genetics, and that's how we diagnose suspected patients with MSUD. The treatment, just like with many of the metabolic diseases, is primarily dietary therapy with protein restriction and avoidance of catabolism. I think one of the, or many of the kind of clinical challenges that we worry about is obviously crises, where patients can present with encephalopathy, cerebral edema, and stroke. As again, with many other metabolic liver diseases, control seems to be more difficult with advancing age, and there's a lot of reasons behind that. Even under the most optimal settings, it's often that we see comorbidities of the neuropsychiatric system with advancing age. And again, these are things from ADHD to anxiety, panic disorders, depression. And so these are comorbidities that often accompany many of the diseases, even when it's recognized and even when it's treated. So what about transplant for MSUD, right? So this is really a fascinating story. So the use of transplant for MSUD was actually, it was an accident. So in 1997, a patient came in acute liver failure unrelated to their MSUD. So MSUD is not one of the diseases that typically causes liver dysfunction. They had a vitamin toxicity, and so the liver was failing because of the vitamin toxicity. Again, if you go back to that paper that Pat published more recently, you'll see in that arrow 1, there's no bright green chartreuse bar because they weren't transplanting MSUD because it hadn't been discovered that this was a real potential therapy. What they saw is that after the patient received their transplant, they had normalization of their amino acid metabolism on an unrestricted diet. So all those branched chain elevations that were being measured so regularly on this kind of protein restricted diet, they came down. They allowed the patient to kind of eat a more liberalized diet, and they didn't go back up. Patient had no metabolic crises, and we still see this patient actually, and she's doing very well. So why not before? Why wasn't this something that had been thought to transplant earlier? Well, it's because what we know about MSUD is that branched chain ketodehydrogenase complex, that enzyme that is defective, the liver only has about 9 to 13% of the total body protein. So a very small amount. Most of it's actually in your muscles, right? And so 1997, this was a case, it was a proof of concept, right? So people hadn't thought that if I just replaced 10% of your protein needs, that I could essentially cure this disease. You know, I mean, I guess people had thought about it, but no one was willing to actually do it until, again, this patient came in with acute liver failure and didn't have any other options. So how does transplant affect these patients, right? So again, this is a paper from Dr. Mazaregas in 2014 looking at our experience with MSUD. And what you see here at the top is plasma leucine levels. That's one of the branched chain amino acids. And you see normally they're in a range, below 200. Those with MSUD, the range is much wider, even when well controlled. And after transplant, what you see is that on an unrestricted diet, those levels come down dramatically. They may not entirely normalize, but they are much, much lower and outside of the range that we would consider dangerous from a neurotoxic standpoint. And when we look at some of the ratios, those are essentially normal up from the two bottom pictures. When you look at the neurocognitive effects, right, what you see, and again, the dot on the left represents pre-transplant testing versus the dot on the right being post-transplant testing, not a lot of benefit is seen from a neurocognitive testing standpoint in these patients. And so what they concluded was that although liver transplant may arrest the brain damage, it doesn't cause any progression of neurocognitive deficits, it doesn't reverse it. So if there's damage there, it's generally not considered to be reversible. Another kind of new fascinating story, particularly as it relates to MSUD, is its use in what we call domino transplantation. So this is something that many of you may be aware of, is that livers are in short supply, right? So here's a picture of it again, the red being the number of organs that are donated, the orange being those who receive transplants, and the blue / green are the patients who are on the transplant waiting list. So much more patients on the transplant waiting list than there are organs available to transplant them. So we need more organs, or we need more options. The current system, at least in the US, for which organs are allocated, called the MELD-PELD system, really is unable to overcome this shortage. It's a supply and demand problem, and it's a big one. So Ajay Khanna, who's now a transplant surgeon here at the Children's Hospital of Pittsburgh, when he was out in California, he and his colleagues published their kind of first reports of what we call domino transplantation. So again, if you go back to that picture I showed before, showing that only about 10% of the protein that the branch chain complex is in the liver, that kind of led to the hypothesis that if I took a liver of someone with MSUD and put it into somebody without MSUD, that they would be able to accept that liver and not get MSUD, because most of their protein would still be functional, it would still be in the muscles, and they would be able to handle their branch chain amino acids. And essentially it worked. So again, this is kind of looking at the experience of domino liver transplant. This is an older paper. We're actually in the process of submitting our most recent experience with, I think, about 25 patients who received domino liver transplants. This is, again, an older version where we only had 7. But the story here is that this is looking at those patients who received a domino liver organ, right? So you had a disease, somebody else with MSUD got a transplant and ended up giving their liver to you. Their outcomes were very good, both from a patient and graft survival, as well as from a branch chain amino acid level, which were essentially normal, which would be expected, right? You have 90% of that protein outside of your liver, so even if you have a liver that's deficient in it, the body's able to compensate. All right, so lastly, what we're going to talk about is Crigler-Najjar type 1. So here it's pretty simple, right? So the substrate is unconjugated bilirubin. The end product is conjugated bilirubin, and there's only one protein that's important in this process, or that's involved in this process, and this is this UGT1A1 glucuronal transferase. When this protein doesn't work, you get elevations in your unconjugated bilirubin. Here's just a picture of that. Again, you see here that UGT1A1, where it is, it's inside the liver cell. Its job is to take bilirubin down below and conjugate it so that it can get out of the liver cell and into the bile duct and out through the intestine. When that protein is defective, you get elevations in your bilirubin levels. So what are the clinical manifestations of a child or a young adult with Crigler-Najjar? This is it. It's a jaundiced infant. So jaundice typically occurs within the first days of life. Now, again, notably, jaundice is common in many babies for many different reasons. But this bilirubin is all, the unconjugated fraction, right? So the total bilirubin will be kind of north of 20, but their direct or conjugated fraction will be quite low. And that really is able to separate out this disease from other reasons why babies can be jaundiced at birth. Now, again, this is just to recognize that, total bilirubin levels above 20 is substantially abnormal. So even in patients who have kind of normal baby jaundice, levels of 20 are many standard deviations outside of what we would expect to see, and kind of reach what we would consider to be a danger zone. If you look at the liver enzymes, they're normal. So AST, ALT, GGT, if you measure them in these children, they're essentially going to be normal. Historically, these children have been thought to have had normal liver biopsies or normal liver histology. This is maybe shifting a little bit, this paradigm. This was a paper we recently published looking at some of our older patients with Crigler-Najjar, where again, on the left, you see what would be considered a normal liver, but in boxes B and C, you see a couple patients who actually do have some suggestions of liver structural damage, which comes into play with some of the therapeutic options. But again, I think most are still considered to have normal histology. They have pigmented stool, which again helps to differentiate it from some of the other diseases that we worry about in infants who come in yellow and jaundiced. Again, just a picture of kind of what normal baby poop looks like. Bottom's normal. The top is what we call acolic stool or non-pigmented stool, which can suggest a real problem. The diagnosis is really made with bilirubin measurements. You follow the clinical course. You can do enzyme measurements looking specifically at that UGT1A1. There's currently about 130 different genetic mutations that associate with Crigler-Najjar type 1. So it's a growing area from a genetic standpoint. So what's the most worrisome kind of a clinical manifestation of Crigler-Najjar type 1? It is this. This is a kind of cross-section picture of a human brain with those kind of yellow areas is something we call kernicters. So that bilirubin, when it gets elevated, particularly the unconjugated portion of the bilirubin, it's able to cross into the brain. It deposits in this area of the brain called the basal ganglia, which causes many problems. So this is also called bilirubin-induced brain dysfunction or acute bilirubin encephalopathy. These are other names for kernicterus. This is possible at any age, so it's not just something that affects the babies. It can affect the older patients as well. Essentially, it's related to the ratio of bilirubin to albumin. So here's a cartoon showing what's normally happening in the body. Again, you see these kind of green semicircles are your albumin or a protein that's in the blood. These things typically carry bilirubin so that the bilirubin can't get across what we call the blood-brain barrier and into the kind of central nervous system. So that's normal. Over here on the left is you see what happens when you have bilirubin levels, bilirubin elevations. So despite the fact that your albumin is still there, that you've kind of saturated its ability to kind of bind this bilirubin. So you have a bunch of free, yellow dots, which are bilirubin, and these things can freely cross into the central nervous system. When they get in there, they cause lots of inflammation and other problems, and that's where you get your neuro deficits. The symptoms are really central in nature, again, common to other metabolic diseases that affect the central nervous system: posturing, hypotonia, seizures, fever, hearing loss, spasticity, cognitive dysfunction. And as again, these neurocognitive deficits, we generally consider them to be irreversible. So if you kind of take a neurological hit, we would not expect as much recovery, although there's different data in different diseases that may challenge that a little bit. So what's the medical treatment for Crigler-Najjar? Well, phototherapy. Again, many babies, for anybody who's ever been in a NICU or in a newborn nursery, will see babies kind of hanging out in these tanning beds. They all don't have Crigler-Najjar. Many of them just have normal baby jaundice. But what this phototherapy does is there's a certain kind of wavelength with which this blue light is able to take that bilirubin and actually kind of reconfigure it to a different structural isomer that's able to actually be secreted in the urine. So bilirubin normally doesn't get put out in the urine, but if you undergo phototherapy, it can kind of change the conformation so that you can do that. It's also important to avoid medications that can displace bilirubin from albumin. Again, albumin typically carries that bilirubin, and if you give drugs, sometimes these can kind of take the place of the bilirubin and increase the amount of bilirubin that can cross into the central nervous system. And then exchange transfusion, sometimes we'll actually have to take blood off, filter out the bilirubin, and then put the blood back in. This is a paper from Kevin Strauss and his group out at the Clinic for Special Children, where, again, kind of showing the story here is that over time, these diseases still are very difficult to control. So, kids who become, teenagers, even with optimal control, and this kind of line represents kind of a danger line for those who may develop kernicterus. There's kind of a steady increase, a steady march over time towards that line. So what about transplant in Crigler-Najjar? So we do it. This is one of the metabolic diseases that we absolutely transplant for. The indication is very clear for the reasons we just talked about. This is the kind of, it's an older paper, but it's the only literature that's out there looking at the experience of Crigler-Najjar. If you look at unpublished data, and again, this is UNOS data from 2016, 67 patients with Crigler-Najjar, 30 years of follow-up, and kind of just looking at the most, the 10-year outcomes, because I think those are the most recent. Graft survival and patient survival is very, very good. So I think transplant is very much a real opportunity for patients with this really devastating disease. But what about some of the alternative or future treatments, right? I think there is this out in the literature, and so what this is a picture of is something we call an auxiliary liver transplant. In this procedure, what they do is they essentially take the liver and they cut it in half. they leave half of the normal liver, or the native liver, not normal, but the half of the native liver with the abnormality in the patient, and then they take a half of a liver from a donor and put that into the patient. Again, kind of if you think back to that MSUD patient, the goal here is to kind of provide enough of a normal protein to be able to kind of handle, dealing with the substrate that's normally not able to be handled with patients with certain metabolic diseases. In this paper, again, from 1999, you had 7 auxiliary partial liver transplants in 6 patients. 5 of the 6 were long-term survivors. This was specifically looking at Crigler-Najjar, and their follow-up bilirubin levels were 1 to 2, so very much in a safe range and outside of what we consider abnormal. I think a lot of people ask questions about auxiliary liver transplant. Our experience at Pittsburgh, I think we've only done 1 of them. They're very technically challenging, and there's not a lot of literature out there about them. And so although it's out there and people will come across it, at least here it's not commonly done, and I think there's a lot of surgical experience that goes into these procedures that we can discuss more if there are questions. What about hepatocyte transplant? This is something that I think a lot of people for many different metabolic diseases are asking about, right? And this is the concept of being able to take normal liver cells, inject them into the livers of patients with metabolic diseases for essentially a gene replacement type therapy, where that normal liver cell will kind of set up residence within all the other liver cells and be able to provide a normal protein. So this was Ira Fox, who's here at the Children's Hospital of Pittsburgh, performed one of the first hepatocyte transplants in 1998. This was a 10-year-old child with Crigler-Najjar type 1. Prior to going into the transplant, the child required 12 hours of phototherapy, so that's 12 hours of sitting in a bed all day under lights. Total bilirubins were still very elevated, 24 to 27. What they did is they took this 7.5 times 10 to the 9th liver cells, they injected it into the portal vein. They gave a medicine called FK or tacrolimus and prednisone, which are medications we give to patients who receive liver transplants as immunosuppression. And afterwards, what they essentially saw was that there were conjugated bilirubin levels measured in the blood of this child. So these cells were able to conjugate bilirubin. After the transplant, the phototherapy went from 12 hours to 6 hours, which from a quality of life standpoint is dramatic, right? If you get 6 additional hours that you're not having to sit under lights, that's a big deal to many of these families. And so that was a huge success. Total bilirubin went from, again, the 24 to 27 down to 14, which is a much safer range. It's by no means normal, but it's the risk of kernicterus would be much lower at a level of 14. Zach Khan, who's one of our hepatologists here, along with Steve Strom, who was at Pittsburgh and is now over in one of the Nordic countries doing his science work. They kind of looked at the kind of the published literature as it relates to hepatocyte transplant, again, just for Crigler-Najjar. What you see here is, most of these numbers are really small. They're dealing with single patients or only a couple patients. The effective outcomes, not 100%. You'll get a 50%, 40%, somewhere between 20 and 50% reduction in the bilirubins, some decrease in phototherapy. But almost all of them, if you look at the outcomes, ended up receiving a liver transplant. And so for Crigler-Najjar, at least, I think, we kind of think of hepatocytes as a bridge to transplant. It has not proven to be a cure as of yet, but a bridge. I think that the area of hepatocyte transplant is one that's fascinating, and I think it's one that is continuing to be explored. There are many diseases where hepatocyte transplant has been performed, and I think a lot of them have various results and outcomes, and we can talk about some of that. I think, understanding how these cells engraft inside the liver and kind of how you would then monitor them for rejection and things like that are really the challenges of this system. We're currently about to open a clinical trial for patients with PKU who would undergo hepatocyte transplant to kind of, again, revisit this, because I think there have been advances, mostly in the lab and in animal models, that suggest that this really could be a successful strategy in the future. And what about gene therapy? Again, I think this is the one that we get a lot of times from many patient and patient families. So this is the idea that you transplant normal genes into cells in place of missing or defective ones. The way that this works is essentially you take a virus. Most of the time, from a liver standpoint, it's an adenovirus for a variety of different reasons. You take the genome or the genes specific to that virus out. So the way a virus is built is you have these kind of capsids or little houses that holds all the genetic DNA of the virus. So essentially, you take the virus, you take the genetic DNA that's for the virus out, you kind of cut it out, you take whatever gene you want and you put it into that viral genome, and then you can kind of inject that virus, that modified virus, into a patient. The idea is that that virus then goes into the liver cells, infects the liver cells, and essentially provides that protein to be able to be built inside the human with the kind of the mechanisms normal to a human in order to provide a gene therapy. So this is really exciting data. This is mouse data, and this is looking at a model of Crigler-Najjar in a gun rat. And again, what you see here is, on the left is your bilirubin. It's all really, really high. And then, these are different doses of gene therapy that were given. But I think at some of those higher doses, again, what you see is, boom, after you give the virus, the bilirubins in these mice can really, really normalize. There's been studies in kind of non-human primates that have shown that this is also safe and that it can be tolerated. There is currently a kind of clinical trial looking at the ability to do this in Crigler-Najjar. This has also been successfully done in patients with other diseases like hemophilia, and so this is something that I think has a real future, trying to figure out how we can kind of provide gene replacement therapy by using viruses and manipulating them. So again, kind of broad strokes, coming back to transplant, right? How do we think about transplant as it relates to metabolic diseases? Well, transplant represents potentially a metabolic cure, right? So for many of these diseases, you do a liver transplant, you essentially cure the disease that had been affecting the child beforehand. That said, in the case of Crigler-Najjar, you still have the specter of kernicterus that is removed. In many other diseases where you have the concern for metabolic crises, liver transplant can remove or dramatically reduce those things, and you have quality of life. Many patients who have undergone liver transplant will testify that their quality of life is dramatically improved by transplant. But transplant is not without risks, right? It's a serious surgery. We're getting a lot better at it. We're very safe at it. Our surgical teams are the best in the world. But there is always a risk, and risk of death is one that is needs to be weighed as you're thinking about transplant. You have transplant morbidities. You're talking about continued lifelong medication, continued lifelong following, continued risks of rejection and other things. Although again, it is much less and much fewer as time goes on. But these are measurable and need to be considered. The commitment to transplant, right? I mean, you're committing yourself to going through this process. You're committing yourself to regular follow-up and regular hospital visits and regular labs and all of these things. And so it's not that you just get a transplant and then we're done. You get a transplant and things are different. And then the future developments, right? We just talked about gene therapy, hepatocyte transplant. What's coming down the pipeline that in 10 years may be able to provide an even better, even safer alternative to transplant. We don't know. I think many of you can probably testify that the medical teams have been thinking about hepatocytes and gene therapy for probably decades, and so it's hard to put an exact time point on when those may become available. But for individual patients, I think that's what they're thinking about, right? If I do a transplant now, does that eliminate the chance of me getting a better therapy down the road? And then cost. Again, transplant is not a cheap intervention, and it's something that will kind of requires lifelong management afterwards. And so these are real, issues that need to be considered when patients and care teams are thinking about how transplant is going to individually be good for their child. So in summary, metabolic liver disease, it's a fascinating area, lots of interplay between multiple disciplines. Conceptual understanding of pathways and physiology can really illuminate disease processes as well as treatment approaches. And at the end of the day, transplant really can represent a metabolic cure. So for many, many patients and many families, it is an excellent therapy to consider or discuss so that you can change the natural history of many of these metabolic diseases. So for more information, I'll leave this slide up briefly. The Center for Rare Disease Therapy, this is the phone number. Please feel free to reach out, call, email, visit us, whatever we can do to help and assist. So I think that's the last slide, and now I think it's time for questions. Went a little bit over there, but I'm happy to stick around a little bit and we can see how this goes. All right, so here we go. So first question so far, right? I'll read the questions to make sure that you guys are able to get them. So can any MSUD liver be used for domino transplant? The short answer is yes. I think that there are size issues that we deal with. So some of our, I think the youngest patient here, and I may be misquoting, that they've used the liver to domino into, I think is a 7 or 9, something like that. The younger patients, 2, 3, 4, 5 range, they have not typically used those livers for domino liver transplant. There are some technical issues as it relates to kind of taking that liver out, where sometimes we will plan on using the liver to domino, but because of various reasons, in the OR, the surgeons decide that the risk isn't worth it. I think, when thinking about domino liver transplant, the priority really initially is for that MSUD patient, right? So the process is, the liver becomes available, it's determined to go to an MSUD patient. That patient is in the operating room getting the liver transplant. And so if the patient that the liver will be dominoed into, presumably is somewhat medically stable, and so I think that if there's any concern that there may be undue risk for that patient with MSUD, I think the surgeons in the operating room maybe decide we're not going to do it. We're just going to do the transplant in this single patient. In some of the Asian countries, there's actually also been reports of taking that MSUD and splitting it. Split liver transplantation is something that is obviously we push for a lot in pediatrics. It's where you take one liver, cut it in half and put 2 pieces into 2 different patients. So it kind of increases, again, that liver pool. There have been reports of patients with MSUD having their liver split and then put into 2 different patients. So that's also out there in the literature. All right, so question here, how do I decide if my child should have a liver transplant rather than managing symptoms? We get this question all the time, and it's one of the most important questions that's asked, and it's one of the most important things to discuss. And I think, I'm going to come at this from the American standpoint, so for any international viewers on the webinar, it may be different where you are. But I think that this is a very personal decision. I think that, the way that the diseases are decided, in the United States, if you have a metabolic liver disease, and it's thought that liver transplant can help it, in that kind of broad list that I put up at the very beginning of the talk, essentially, that's an automatic rubber stamp to be able to be listed for transplant. Now, that does not mean that a transplant will come quickly. That doesn't mean that there aren't other things that the care team needs to kind of look at. There's a variety of different things, and if any of you have been through the process, you know that. But the underlying indication, my child has X disease, you will automatically be considered because of that for liver transplant. There are, very few metabolic diseases where we would say you have a disease, but we would not consider transplant. And so at the end of the day, a lot of times it does come down to, how difficult has it been to control my child's symptoms? What is the level of anxiety? What is the risk of my child at any time point kind of going into a metabolic crisis and developing one of these neurological complications that, as we talked about, are oftentimes irreversible? Do we do this preemptively before any of it develops? Do we wait a little bit until it gets a little bit more harder to manage? These are very, very, very great, complex, and personalized questions. I think how I see my job is to educate families on how transplant can be beneficial, what it means after transplant for you and your individual child and your individual disease, and then kind of help along with the team. You guys come to a decision that seems best for you, right? If you have a patient with MSUD who's well controlled, who's doing great, and you decide, transplant's not the time for me right now. I think we're doing good. I think that's a perfectly acceptable and fine decision to make, recognizing the risks that come with living with MSUD. If you say, you know what, it's worrisome. We've had one crisis that put her in the hospital, and that scared me enough. And even though she's doing great now, I think that I think we want to go ahead and pursue liver transplant. I think that's also fine. So, long answer to, it's a difficult personal decision. And I think at the end of the day, I think physicians and surgeons and care teams and geneticists and counselors, we're here to help. And we're here to answer questions and kind of try to come to the best decision with you and with your child. So question here, has any MSUDs died from transplant? Our experience is no. There have been no post-transplant morbidities. with patients with MSUD. Now, again, most of these patients with MSUD are only 10 to 15 years out, which is not to say that's not a lot, but liver transplant, in any serious form really dates back to the 80s. And so, when you're looking at kind of 30, 40-year outcomes versus 10, 15-year outcomes, I think there's some big differences there. But our experience, there's been no morbidity for MSUD from liver transplant. I'm sure there are other institutions where maybe that's not the case, and I can't speak for every MSUD patient, but I can speak for our patients here. All right, next question. How low are immunosuppressants usually taken post-transplant in an average situation? Another excellent question, right? Immunosuppression, that's the big kind of scary thing that everyone worries about post-transplant, because that's where we see a lot of our complications. I think, speaking purely from a liver standpoint, we are extremely lucky. The liver is really considered to be a very immune-tolerant organ. So in some of the other organ transplants, heart, lung, intestine, bone marrow, being able to kind of reduce immunosuppression and even come off in certain circumstances is not a reality. For the liver, though, the short answer to the question is the right amount of immunosuppression is as little as possible. I think the ideal outcome would be a patient that's on a single medicine at a very low dose that they take every day. Once they're kind of a year, 2, 3 years post-transplant. I think the expectations would be that immunosuppressants are taken for life. There is some question, and there is some data actually, that there is a subset of patients that can come off immunosuppressants completely. Now, again, we're talking about the liver, and this was mainly done in patients who had complications where the medicines needed to be discontinued, and kind of once they were, and the patient recovered from the medical issue. They kind of said, hey, look, the liver looks okay. The liver numbers are normal. They haven't gone up, and patients have really been able to stay off immunosuppression. There's a lot of interest in trying to understand who those patients are. We're actually involved in a clinical trial called IWITH, which stands for Immunosuppression Withdrawal. And so this is an NIH-funded study that's really trying to identify, can we predict which of these patients are able to come off immunosuppressions entirely? I think that that's the future. When I talk to patients now, I think the party line should be the expectation is that it's a lifelong immunosuppression. We minimize it, and we try to minimize it quickly and safely over kind of the first 12 to 18 months after transplant. And usually when we're able to get down to those minimal doses, the complications of immunosuppression are much, much less. So I hope that answers your question. All right. So I have a question that says, can you go into complications more with MSUD after transplant? I think complications, I don't think we have to be specific to MSUD there, right? MSUD, as with many metabolic, based liver diseases, transplant essentially is considered a metabolic cure. Now, there's a few subsets where, again, you may have some extra hepatic or outside of the liver complications that needed to be monitored for that liver transplant doesn't fix, and we kind of talk more about that. But for MSUD and many other kind of metabolic liver diseases, we consider liver transplant to be a metabolic cure. So we would not expect to have any, complications related to the metabolic disease in the post-transplant setting. And the complications that we would expect are more generalizable to just post-transplant complications. I think post-transplant complications, can kind of be grouped by, broad terms and also time points. I think obviously early post-transplant, there's surgical complications that need to be considered. Sometimes you can have problems with the way that the blood supply was provided to the liver transplant. I think another broader group is obviously immunosuppression and medication related. And again, those would not have necessarily anything to do with the metabolic disease, but more related to just post-transplant complications. I think that these are, it's a great question. It's a very long one. And I think, again, it's one that, when and if you would decide to consider transplant as an option for your child or for yourself, these are one of the things that, and we didn't really talk about this, which is, what is the transplant experience, right? And again, speaking from our institution and some of the others that I've been at, there's a whole evaluation process that occurs when you're thinking about transplant for your child. You come to the hospital, you meet the entire care team, the hepatologist, the transplant surgeons, social work, in the case of metabolic disease, our geneticists, any other subspecialties that we would think needed based on, again, your child and your disease. And it's really that kind of, it's a multi-day, evaluation process where that's where you get a lot of the education. That's where you get a lot of opportunity to ask questions, get information about, how transplant, what transplant means for you. Again, answer the question, the complications would not be specific to MSUD, but would be more related just to post-transplant care, because we would expect the MSUD to be cured by liver transplant. All right, next question here. We have, when a child had a metabolic disorder, can any organ transplant jeopardize the quality of life? Is there a difference between a liver or a kidney transplant as far as one is more dangerous than the other? I think it's a good question, I guess I don't know if it's an easy answer. There are different challenges and opportunities to challenging opportunities to different organs, right? Not every organ is the same. Not every transplant is the same. For example, you mentioned liver and kidney. Liver transplant, we have one of the advantages of that it's a really immune tolerant organ. So we can sometimes handle certain things like a little bit of rejection, like decreasing immunosuppression medications in case of viral infections or other things. From a liver standpoint, the liver really does pretty well with those things versus other organs like, again, heart, kidney, intestine may not do as well. On the other side, something like a kidney, which you mentioned, kidney transplants, again, I'm not a nephrologist or a kidney transplant specialist, but, they generally do very well as well. Outcomes are very good. They have the advantage, though, of at the end of the day, if the kidney fails again, they have a renal replacement therapy. So you can go back on dialysis, not that that's the outcome people are looking for, but you have the opportunity to kind of go back onto dialysis should that kidney transplant begin to not do as well as it had earlier on. Our heart colleagues don't have either of those options. They have an organ that is not really immune tolerant, that you can't really come down on medications too much, but also just can't be replaced very easily. And so I think, these are very kind of organ-specific questions, and a lot of it depends on, again, which organ is being transplanted. Hope that answered your question. All right, next question. Do you have to transplant a whole liver into an MSUD? No. Well, we particularly in the pediatric side really advocate for and push for this kind of concept that I mentioned, which is split liver transplant. There's an organ shortage out there, and I think the ability to take one generally adult organ, it has to be an adult organ, kind of split it anatomically into two pieces and put those two pieces into two individuals, it really represents a great opportunity. Now, there are some size issues that come into play. You have to be a little bit careful. It's not that those two pieces can go into anybody. But sometimes we'll split into what we call the right and the left lobes. The left lobe is generally smaller and may go into a pediatric patient versus the right, which can go into an adult. So there's some technical issues when we're talking about splitting liver transplants. But a MSUD patient can receive a split liver. I think probably the question is being asked is because, again, you talk about that 8 to 13% of the enzyme. I think that split livers have been put into MSUD patients. We monitor them post, and they have done generally well. Okay, I have next question. Says, my son is 4 months old and has CNS type 1. Would you recommend waiting until he is older to do a transplant, or is it safe now? Again, similar to what we've talked about before, very, very personal decision. I think the underlying disorder of CNS1 would make him an automatic candidate. So if you went to a transplant center and said, my son has this disease, is he a candidate? The answer is yes, even if he is very well controlled on phototherapy or whatever treatments he otherwise may be getting. This is, again, I showed the picture of the kind of scales, right? Liver transplant can cure Crigler-Najjar, and we know that. Does that mean in 5 years there will be a viral gene therapy that's also a metabolic cure that would have kind of prevented the need for liver transplant? I hope so, but I'm sure that's something that probably people have been talking about for 15 years. So I don't know, and no one has a crystal ball or can effectively predict the future. I think that this is where discussions with your care team, with your family about what is going to be best for your child, recognizing that again it only takes one hit, right? And I think this is something that everybody on this webinar knows well enough. That one metabolic crisis can really be devastating, and kind of living under that kind of constant threat is a real challenge for families dealing with these diseases. But to answer, is it safe? The answer is yes. Liver transplant, we definitely perform it to children much younger than 4 years old. So being 4, if that was part of the question, is it safe for a child that young to undergo liver transplant? Absolutely. Okay, so if given a choice between gene therapy and having a transplant, how does one choose which is best? Guys, it's a great question. I think right now there's much more robust data on liver transplant, right? So in the reality and restrictions of today's environment, I think liver transplant we can look to, and hopefully I presented a lot of the data that shows that it is an excellent therapeutic option for children with a wide variety of metabolic diseases. That said, right, if you asked that question, well, you wouldn't have asked that question, right? If someone were to ask that question in the 1970s, right, about liver transplant, people would say, we don't know, right? I mean, there's been a couple cases of liver transplant. It looks like it's done okay, but there's been some not as great outcomes, but no one could have foresaw what it was going to be like in 2019. So I don't know what it's going to be like in 2024. I, like everyone else, have a lot of hope and expectation that things like gene therapy and hepatocytes, which really enable a less invasive way to provide gene replacement therapy, I hope that that's the future. But when you ask that difficult question of how long do I wait, when's the best time, I don't think anybody knows the answer to that. And if they say they know, they're probably lying. All right. Can you go into how the domino transplant works in the way that the person who gets an MSUD liver does not have MSUD from getting the liver from someone with MSUD? Again, great question, right? I think, going back to the thought of, the MSUD is a deficiency in this branch chain ketodehydrogenase. So this branch chain complex. That protein, that branch chain complex protein, is in the liver, and it's also in all of your muscles. Only about 9 to 13% of that protein is actually located in the liver. So if I don't have MSUD, but I go into acute liver failure, or I have a metabolic liver disease where the deficit's in the liver, let's say I have a urea cycle defect or Crigler-Najjar, right? Crigler-Najjar, I don't have the ability to break down bilirubin, but my liver does have a normal branch chain complex, and my muscles have a normal branch chain complex because I don't have MSUD. The patient with MSUD, they will get a liver transplant from another donor. And then that liver from the MSUD patient goes into me. They take out my Crigler-Najjar liver and put in the MSUD liver. Now, what you've done is you've essentially replaced what was my deficit, which was the UGT1A1 deficit, the Crigler-Najjar deficit. And yes, that liver doesn't have the branch chain complex, but all my muscles do, right? And so all my muscles have the ability to break down those branch chain amino acids, even though my liver doesn't. And so that's where, again, you have the ability to take a liver that's deficient from an MSUD standpoint and put it into somebody who does not have MSUD, because their muscles are able to kind of compensate for that liver that doesn't have that single gene, right? Because in metabolic diseases, most of the time we're talking about one single protein, one single gene that's defective and that's causing all of these problems. And so if we can replace just that one gene, we can really, make a huge difference. And so for the domino transplant, you're replacing the defective, gene with a liver that has a defective MSUD protein, but the person who receives that liver has the MSUD protein in all of their muscles. I hope that's clear. It's a complicated and complex kind of story, and it's fascinating. That again, I could talk for a while about it, but that's essentially the gist of it. All right. Next question here. So we're coming up on 3 o'clock. I'll go as long as I keep getting fed questions. I appreciate all the enthusiasm here. And again, this will be online, and any questions that we don't get into, make sure that you email us, and we'll try to get back to you as quickly as we can. So can someone who is bad with staying on a diet with MSUD get a transplant? Absolutely. Right. So again, when you go through a transplant, so that's one of the main indications, right? A very difficult to control patient. Now, when you talk about non-compliance, we know that these diseases are very difficult to control, and so we don't necessarily fault, those patients who have difficult to control disease. Now, when you come for a transplant eval, that is one of the things we talk about, right? Because we know post-transplant, we expect as a care team that our patients are going to listen to our advice, take medicines that we prescribe, take medicines in order to make sure that their liver stays healthy. And so, what we try to do as part of that eval, if a patient were to come and say, I have MSUD, and I'm terrible at keeping my diet, and so that's why I want to, undergo transplant, we would still absolutely, talk about how transplant's going to help that individual patient. But we would also kind of, hammer home the point that, look, after transplant, though, we're going to need you to kind of be able to help work on making sure that we are compliant, that we do take our medicines, that we do come for follow-up, that we do get labs, because at the end of the day, we're just trying to kind of provide the best optimal care. And transplant is also a blessing, right? I showed that graph. Organs are in short supply. There's lots of kids on the wait list. There are kids who still die on the wait list. And so, we are still, somewhat protective of that kind of that gift of transplant, and want to make sure that our patients who are receiving that gift are also going to be able to, care for that gift, and be the ones that are going to be able to, once they get the transplant, do what is needed in order to make sure that those outcomes are as good as they can be. All right, next question. Is there any data on lifespan of a transplant liver in kids with metabolic disorders, or is this still too new and too individualized? Again, great question. I think when you looked at some of those, overall trends, it's difficult, right? And I wouldn't say it's too new, but what I think we can say with confidence, I think we can confidently talk about 20-year outcomes, which is probably not the answer that any parent wants, right? So 20 years for my 5-year-old is not the answer I want. We want 50, we want 60, we want 70-year outcomes. Those we don't have. As I said, transplant really has only kind of come into its own in I would really say the 90s, but in the 80s it was still somewhat pretty experimental therapy. And I would say the modern era of transplant, when you're talking about kind of surgical techniques, immunosuppression regimens, and different things like that, and monitoring strategies, I would say that's really only occurred, kind of early aughts, kind of late 90s, early aughts. So if you're thinking in that time point, we really only are in about that 20-year window. And so when I talk to families, I can kind of talk about, what I feel comfortable with is, we talk about patient and graft survival, right? So, is that transplanted liver still in that patient, and is that patient still alive? And those are around the 85 to 90% at 20 years. And that's pretty good, and that's a lot better than it was, again, if you looked at that first graph that I showed for metabolic disease, looking at the 80s, where it kind of fell off very, very quickly. But, it's a question we talk about every time we do a transplant eval, right? So, my child 6, what's it going to be like when they're 50? That we don't know, because there aren't patients who were transplanted 50 years ago who are still able to kind of provide any meaningful data. Again, there's a few cases here and there of a patient transplanted in the 70s and the early 80s that's still alive and doing well. But, I'm not going to make any recommendations based on 10 people. We need a lot more, we need this kind of wave of a generation of transplant recipients to kind of help guide us on what the future is going to hold. Next question. So what about propionic acidemia? What is the percentage of the disease will come back? Did the transplant help PA patients with their cardiac complications? So this is an excellent question. So we didn't talk about this disease or group of diseases. There's kind of two that go together. These are the organic aciduria, so propionic acidemia and methylmalonic acidemia. We do have a recently published experience here from Pittsburgh that we're welcome to send out for you to review. I think the short answer to your question is, so the PA and the MMA, these are two of the disease processes where the protein is in the liver, but it's also outside the liver. And so what we know about transplants, and again, the numbers are still quite small, but what we know is that transplant for these diseases is generally very good at some of the metabolic control. It's very good at preventing metabolic crises going forward. But it is not, unlike some of the other diseases that we talked about, considered a metabolic cure, because there is still enough of the defective protein around to still cause some of the problems. But I think in our experience here at the Children's Hospital of Pittsburgh, liver transplant for PA and MMA, we were able to really show a dramatic improvement in metabolic crises that have occurred, and the survival of those patients, with again only 3-4 years of outcome, is quite good. And that's actually counter to what has been reported in some of the literature where the outcomes have not been that good. So I think that is somewhat novel. You asked the question about the heart complications, and again, this is for patients with propionic acidemia. They are known to have cardiac defects at certain points. Again, a lot of this is kind of very, very small numbers, but I think what the data does suggest is that liver transplant definitely can halt the progression of the cardiomyopathy that's seen in propionic acidemia. And again, our paper here reaffirms what some others have reported as well in their individual series. I think there is some suggestion that maybe there is improvement. I think, I hedge there because I think it's a little disingenuous to be overconfident in that statement. I think we tell patients that we would expect the heart disease not to progress, and we would hope that we see some of the improvement. But I think the numbers for this disorder and the complexity is still, the numbers are really small, complexity is very high, and so I think generalized statements are still very, very difficult. But it's an excellent question. See. I don't have any more questions that have popped up. So I think we're 7 minutes after the hour here. Again, if we didn't see your question come through, or you have one that you weren't able to post, please reach out to us, email us, call us. We'll make sure we do what we can to get you your answers. I hope you enjoyed the webinar. I hope it was informational. I hope it was educational. If there's anything we can do here at the Center for Rare Diseases, just got to let us know. It was a pleasure speaking with you today. You all take care.